this online teaching program on hemophilia today. Welcome all the trainees and all faculty, particularly our invited faculty, senior faculty, Dr. Tulika ma'am and Dr. Archana from Manipal. Welcome to all the trainees. Hemophilia is an important topic for all hematologists, oncologists. We frequently come across it, whether it's at tertiary care or primary or secondary care. So it's really important for all of us to understand the basics as well as the advances. So without further ado, I welcome Dr. Chandana, who's a fellow in pediatric hematology oncology at Manipal Academy of Higher Education, Mahe. Welcome, Chandana. She'll present the case first. Followed by that, Dr. Archana, who's assistant professor and faculty at Mahe, will present some approach and basics of management. And after that, our senior faculty from AIMS, Dr. Tulika ma'am, will talk about inhibitors and advances in management of hemophilia. So Chandana, welcome. Over to you.
Thank you, ma'am. Good evening, all. My slides are visible.
Yes, slides visible and you're audible. Can you flip to the next one so we know
Yes,
you can?
Yes, ma'am.
Yeah, fine. Moving as well.
Yes, ma'am. Presenting the case discussion of Master MS, 15-year-old male child hailing from Udupi, Karnataka. Starting with the chief complaints, child was a known case of hemophilia A. He presented to the hospital in 2021 with history of slip and fall at home, followed by pain and restricted movements of the right lower limb, especially below knee, and no history of loss of consciousness, ENT bleed, or any visible bleed or hematoma at any part of the body. Coming to his past history, mother noticed a few ecchymosis at the age of 3 months. However, at the age of 6 months, he presented with a history of gum bleeding and ecchymosis. It's the same point where he was diagnosed as severe hemophilia type A. His annual bleeding rate was 8 to 10 times per year, and his target joints were bilateral knee and bilateral elbow, which has the features of chronic synovitis. Point to be noted here is he was not on primary prophylaxis. Coming to the other significant bleeding history, he had intracranial bleed twice till now. Once first bleed was at early infancy and second was at childhood, which was followed by a trauma. Both were managed conservatively. Following circumcision surgery, he had excessive bleed, and once he had psoas major hematoma, which was also conservatively treated. He has history of hematuria, which was treated for like almost 5 times. The key point here is he was multiple times intensively treated with clotting factor replacements from the early age itself. In 2018, at the age of 12 years, he presented with multiple episodes of hematuria, hemarthrosis, and right psoas major hematoma. And his frequency of visit to the hospitals has increased. So he was treated with factor VIII concentrates. Whenever factor VIII was not available, he was treated with the cryoprecipitates as well. But the effective control of hemostasis was not great, unlike before. That was the time he was tested for the inhibitor, and which was positive, 1.2 BU. So far, to understand the gravity of his problem, he was admitted multiple times to the hospital. Total number of hospitalization being 18. However, from 2018, his hospital visits were significantly increased, and many times he was managed on the daycare by factor replacements. Length of each hospital stay is an average of 4 to 5 days, and frequency of hospitalization was 3 to 4 admissions per year. So he was multiple times intensively treated, and as well as he has received intermittent short-term prophylaxis. Coming to his family history, this child was born as a first child to a non-consanguineously married couples. He has one more sibling who is suffering from hemophilia A, who is twin, but twin to the another boy, but the other twin is completely normal. There is no family history of hemophilia as such, and there is no history of bleeding in any of the family members. However, genetic testing was not done. Birth history, uneventful birth and uneventful neonatal period. Immunization history, he was immunized completely as per UIP schedule. However, hematomas and bleeding following immunization was not documented. Developmentally, it was appropriate for age. Coming to the examination, child at the time of presentation to the hospital was conscious, cooperative, oriented to time, place, person, and there was no pallor, ictus, clubbing, cyanosis, lymphadenopathy, or edema. Vitals were stable. He was weighing approximately 60 kgs. Systemic examination was within normal limit. Coming to the local examination, local examination of the right lower limb showed diffuse swelling and tenderness of the middle one-third of the right leg with the painfully restricted movements at the right knee joint. Active movements of the toes were positive. Compartment was soft, no pain on passive stretch. Distal pulses were well felt and sensations were intact. Swelling over the bilateral knees were noted as well. Initial evaluation with an X-ray showed transverse fracture of the tibia and fibula, which mandated the surgical intervention at presentation. So we investigated for the basic blood investigation. HP showed 11.4 gram per deciliter, platelets 317,000 per cubic millimeter. Prothrombin prime was normal. APTT was prolonged, 89.9 seconds. Factor VIII level was continued to be less than 1%. Inhibitor screen was positive, and inhibitor assay showed 23 beta-zeta units. Impression here here is severe hemophilia A with high responding inhibitors. So from the time of hospitalization, he was managed by orthopedic team and PHO team. He was immobilized initially till the surgery was facilitated. He was immobilized by cast and splint application. At this point of time, the bypassing agent we had was recombinant factor 7, that was Nova 7. We administered at 90 micrograms per kg, that is 5 mg as per the existing guidelines, immediately as soon as we saw the patient, and the continuous efforts has been made for procuring FIBA as well. And local measures like ice pack application and Tranexa was continued, and along with the FFP transfusions. We also had kept a close watch for compartment syndrome and bleeding. We were fortunate to receive the FIBA by day 4 of hospitalization. So this was the guidelines. Once we had the FIBA in hand, child was posted for surgery. In the pre-op time, we gave injection FIBA 3000 units, that is approximately 50 micrograms per kg, 1 hour prior to surgery. And in the intra-op period, we gave a clear instruction that no epidural or spinal anesthesia, and child underwent intramedullary interlocking nail for tibial strap fracture under general was tolerated well, no intra bleed. Post-op injection FIBA was continued 8th hourly on the day of surgery. Child tolerated the procedure very well. So coming to the post-op days 1 to 7, hemostasis was under control. Injection FIBA was tapered and stopped gradually, which was made to 2000 units, that is 35 micrograms per kg 12th hourly, along with the Tranexa and local measures. Once we were sure of hemostasis, we encouraged him for early mobilization with by 3rd or 4th day. But on day 15, post-op period, child developed delayed bleeding from the wound site, and along with that, he had right knee hemarthrosis. So again, we repeated injection FIBA at 2000 units, followed by Tranexa till the bleeding stopped. Hemostasis was well controlled. 48 hours post FIBA, that is on post-op day 17, we had given injection emicizumab 180 mg, that is 3 milligram per kg subcutaneously, one dose. This is for in view of anticipatory bleeding which might happen during the rehabilitation physiotherapy, and also to facilitate healing. So when hemostasis was very well achieved and child was made ambulatory with the help of physiotherapy in next 2 to 3 weeks. Currently, past 1 year from the surgery, child is completely fine, now ambulatory on his own. So, to summarize, is a case of severe hemophilia A with high responding inhibitor, presented with fractured both bones right leg, and he was managed with a combination of recombinant factor 7, FIBA, antifibrinolytic agent, and alternative standard of care, a single dose of emicizumab during rehabilitation. Thank you.
Thank you, Chandana, for that very clear presentation and highlighting several important aspects, which I'm sure Dr. Archana and after that Dr. Tulika ma'am will go into. Can I request Archana to proceed with the next part of the talk, please?
Good evening, one and all. Hope my screen is visible.
Not so far, ma'am. You can still see the thank you slide of the previous presentation.
Okay, sure. Now, can you see the slides?
Yes, ma'am. Yeah, you are audible also.
Sure. Thank you. We just had a discussion about one case of hemophilia with inhibitor. First of all, I would like to thank Pediatric Hematology and Oncology chapter of Indian Academy of Pediatrics for giving this opportunity for KMC Manipal. I'm going to talk about the epidemiology, risk factor, and screening for inhibitors in hemophilia. There has been significant advance in management of hemophilia in the last 2 to 3 decades. Initially, we used to use the plasma based therapy, then we had plasma derived factor, then recombinant factor. Now we are moving on to non-factor replacement therapy. Though the prophylaxis is a standard of care, we are not able to provide for all, but at least we have started now. And also there is a lot of advance in surgical management, which have reduced the chronic debilitating problems for hemophilia patients. During this course, the most serious complications of classic hemophilia treatment is the inhibitor, because once the inhibitors are formed, there is high rate of hospitalization, greater treatment cost, and high mortality rate. So these inhibitors were actually described in 1941 itself. Since then, there is a lot of research regarding the risk factors, their pathophysiology, but it's still a gray zone. And inhibitor development is a multifactorial event. There is a complex interplay between several genetic and non-genetic risk factors. Inhibitors are the antibodies against the infused factor, either factor 8 or 9. Due to immunological reaction, multiple antibodies can form, but only the inhibitor can neutralize the function of infused clotting factor concentrates. So these are the allo antibodies which will neutralize the infused clotting factors. They are of IgG class, especially IgG1 and IgG4 subclass. These inhibitors are encountered more frequently in hemophilia A than hemophilia B, in severe disease than in moderate to mild hemophilia. In severe disease, we see these inhibitors in younger patients, mild to moderate cases in the later age group. And it is detected and quantified by Nijmegen modified Bethesda assay. Usually, more often we detect them during screening, sometimes during whenever there is poor response to factors. So once we detect, there is a great challenge in controlling bleed and managing their higher disease burden. So coming to the epidemiology, as I mentioned earlier, hemophilia A has a higher incidence, 30% among previously untreated patients, hemophilia B up to 5%. In mild to moderate cases, we see in 5 to 10% of 5 to 10% risk. So before going into some evidence, I would like to explain 2-3 terminologies, especially for the trainees. That is, one is exposure day. This is a 24-hour period in which patient has received at least one infusion of the factor. And there is something known as previously treated patient. That means these are the patients who have received at least 150 exposure days, and previously untreated patient, that is PUPS. And that means they have not received any factor concentrate, or they've received minimal treatment. Actual definition is 4 exposure days. So coming to the relationship between the exposure days and inhibitor formation, you can see in this graph, the most of the inhibitor happens in the first 20 exposure, nearly 79%. And the median period to develop inhibitor is 10 to 15 days. After this Vandenberg et al., this study, they have considered even 75 exposure days should be the cutoff to distinguish PTPs, that is previously treated patients. A small note on hemophilia B and inhibitor. In hemophilia B, the inhibitor chances are less and seen exclusively in patients with severe disease. And the peculiarity here is they might develop anaphylaxis or allergic reaction. Allergic reaction might be the first symptom of inhibitor development in factor IX inhibitors. And whenever we choose bypassing agent, we choose recombinant factor 7 over APCC, because APCC has some small amount of factor IX, which can trigger anaphylaxis in these patients. Same time, when these antigen antibody complex will deposit in the kidney and can trigger nephrotic syndrome as well. So most important thing, the risk factor for inhibitor development, we have 3 category of patients. One category, inhibitor will never develop. We have one more category, inhibitor will develop whatever our treatment strategy or protocol we use. And we have patient whom the inhibitor development depends on what the treatment we choose, we advise what factor we choose. So we have to target them. For that, we need to know what are the potential risk factors. We have modifiable and non-modifiable risk factors. Non-modifiable ones are the genetic ones. The most important and proven risk factor is the type of mutation. If the mutation is null mutation, in case of large deletion, multi-domain deletion, the risk of inhibitor is very high, nearly 75%. And the most common mutation, what we see in hemophilia A, intron 22 inversion, has intermediate risk of inhibitor formation. Non-null mutations have low risk for inhibitor formation. Next thing is the family history. If a child or a adolescent who have a family history of inhibitor, uncle or sibling who had inhibitor means, then the risk will increase by 3.2-fold. Black population is at higher risk of inhibitor formation than the Caucasians. There are some polymorphism in immune regulatory genes, especially TNF-alpha, IL-10, CTLA4 can predispose these patients to inhibitor formation. Similarly, H3, H4 haplotypes and MHC gene classes HLA-DR15, HLA-DQ6. And the potentially modifiable ones, that is environmental risk factor, includes peak treatment moments. Whenever you treat the patient intensively following during surgery or following trauma, they are at an increased risk. Intense exposure in early life age, less than 1 year, intense exposure is at higher risk. If you are exposing them to factor during infection, inflammation, they have a higher risk, but still we don't have robust evidence for this. and also the factor concentrate type and early initiation of prophylaxis has some effect. Let's discuss in detail about this. So before that, for the trainees, I've been discussing about many terminologies like CFCs, plasma derived and all. Small note on this. The clotting factor concentrate are divided into plasma derived and recombinant ones. Plasma derived factors are produced by a procedure known as plasma fractionation. Recombinant factors are produced by genetic engineering and either animal or human cell lines. Depending on their protein content, what is the purification used, what is the protein structure, depending on that, we have different generations. Now with FC fusion and pegylation, we have extended half-life products as well. Depending on the protein structure, we have full-length product and B-domain deleted or truncated products as well. So the known fact here is plasma-derived factor has reduced immunogenicity. So it is due to the complex with von Willebrand factor which will mask the critical epitopes on the factor VIII so that they are less exposed to the host immune system. And also there are some immunomodulating protein in the plasma which will reduce the immunogenicity of plasma-derived factor VIII. Let's see some evidences, early evidence from the canal cord study between 1990 to 2000, which showed regular prophylaxis was associated with 60% lower risk than on-demand treatment. It is due to the inhibition of immune response through peripheral energy of the factor-specific T lymphocytes. Same study also highlighted the formation of inhibitor in the early exposure days, that is within 20 exposures, and also increased risk of inhibitor if they are getting the factor in a very early age, like less than 1 month has a 41% risk, when compared to 18 months and more has a 18% risk. But in this study, they ascertained this fact to the intensity of treatment, and they highlighted saying avoiding early elective surgery and intensive therapy will help to prevent the inhibitor formation. The Rodin study between 2001 to 2010, which is a non-randomized, non-controlled observational study, which studied the inhibitor incidence across the plasma-derived and recombinant factor, which showed almost similar incidence between the plasma-derived and the recombinant one. Only thing was the second generation full-length recombinant factor had a higher incidence of inhibitors with the hazard ratio of 1.6. So key conclusion of Rodin study was recombinant and plasma-derived factors had a similar risk. Switching from plasma-derived to full-length recombinant product did not increase the risk of inhibitor development. And the second generation full-length product had an increased risk of inhibitor development. Same Rodin study also highlighted the protective effect of early prophylaxis. A systematic review by Iorio et al. Did not prove or disprove the hypothesis of risk of inhibitor is more with recombinant than plasma-derived factors. There is a 20-year-long birth cohort study, including nearly 900 patients of canal study and PEDMEC registry, which showed that there was a cumulative increase in inhibitor incident between 1990 to 2010. These inhibitors were like more of low titer inhibitors, and the incidence of high titer inhibitor was quite stable. They explained this fact saying there were we are testing the inhibitor more frequently, and there are more sensitive laboratory assay which is available, because of which the incidence is being shown high. The popular study, survey in inhibitors in plasma product exposed toddlers, SIPIT study. It is a prospective randomized trial, including 251 patients, that is previously untreated patients. Again, they have not exposed to any factors or exposed minimally to factors. It showed that the incidence of inhibitors in plasma-derived factor was 26% against recombinant factor 44%. The key conclusion here was early replacement therapy with plasma-derived factor VIII was associated with lower incidence of inhibitor development. Then European Medicine Agency in September 2017 released a statement that there is no clear and consistent evidence of difference between the two products. Meanwhile, we had extended half-life product with us. So PUPS A long study was done, which is the first study of extended half-life recombinant factor VIII in previously untreated patients with hemophilia A, showed similar incidence of 30%, 31.1%, and high titer inhibitor 15%, which was similar to other factors. So conclusion is all factor concentrate carry a risk of inhibitor development, whether it is plasma-derived or recombinant clotting factor concentrate for PUPs, whether all recombinant factor VIII concentrates carry the same risk of inhibitor is a topic of debate. So still we tend to switch the product. There are many product-specific consideration. Recombinant product have improved safety profile, especially prion disease for non-envelope viruses, fewer side effects, the infusion reactions, longer half-life. Most of the time, we tend to switch the product not by choice, but by availability. There will be some shortage or termination of product supply. Because of these reason, we might switch the product. How do we diagnose inhibitors? We do inhibitor screening, that is incubated mixing study, where we mix 1:1 ratio of patient plasma and normal pooled plasma, and we incubate at 120, incubate for 120 minutes, and we repeat a APTT. If it is delayed, that means there is time dependent inhibitor, which is suggestive of factor inhibitor. After that, to confirm and to quantify, we do the Nijmegen modified Bethesda assay, which is a quantitative test. One Bethesda unit is defined as the amount of inhibitor that neutralizes 50% of the factor in 1 ml plasma. The incubation period, incubation time, what is there for factor VIII and factor IX is slightly different because of difference in the inhibitor kinetics. And the positive inhibitor is more than 0.6 BU for hemophilia A, 0.3 BU for hemophilia B. So depending on the factor titer, we have low responding inhibitors and high responding inhibitors. Low responding inhibitors means that titer is less than 5 BU, and these low responding ones tend to be transient. We will have to repeat the Bethesda assay once every 2 to 4 weeks for up to 6 months to know whether they are transient or persistent. High responding inhibitors are the inhibitor titer more than 5 BU. These high responding ones are usually persistent. Sometimes when we measure the inhibitor titer, they can be low responding inhibitors. Because of anamnestic reaction, the titer may increase exponentially after exposure to factors. So when to suspect inhibitors? This is the most important point here. For any recurrent bleed or target joint bleed, in spite of giving adequate factor replacement, if you have given adequate factor, still the response is suboptimal, or if the patient continue to bleed, if they develop some unusual site of bleed, suddenly some genitourinary bleed, mucocutaneous bleed, if they have received any intensive therapy, like for management of trauma, surgery, the intensive therapy is defined as daily exposure for more than 5 consecutive days. Whenever we check for recovery, if the target level is not achieved, and if the patient develop allergic reaction or anaphylaxis following factor infusion in hemophilia B, we should suspect and test for inhibitor. So these inhibitors should be monitored regularly. It is better to monitor and detect the inhibitor rather than coming to know that the patient is inhibitor positive when he is bleeding. If the patient is on primary prophylaxis, it is advised to test every 3rd or 5th exposure day until 20 exposure. If the patient is on on-demand therapy, at least once every 3 months until 20 exposure days. then every 10 exposure days between 21 to 50, then every 3 to 6 monthly up till 100 to 150 EDs. It is mandatory to test inhibitor before elective surgeries or invasive procedure. Whenever there is suboptimal response, either clinical or laboratory, that is factor recovery, once or twice yearly for each and every patient with hemophilia. We have to be more vigilant if there is a family history of inhibitor. Before and after switching the factor concentrate, and 2 to 4 weeks after the intensive treatment, especially for surgery, trauma. Again, intensive treatment is daily exposure for more than 5 consecutive days. So our data, we have 392 patients. We have a comprehensive clinic running on every fourth Saturday of the month. We do inhibitor screening for all the patients. And we have 10 patients with inhibitor. We have not done any ITAs so far. No one on primary prophylaxis, but we do for secondary prophylaxis. The protocol for our inhibitor screening is for everyone we do once a year. If they are on secondary prophylaxis, baseline and 4 weekly, we will monitor. And among these patients who have received secondary prophylaxis and the patients who have undergone major surgical interventions, so far we have not encountered any inhibitor. Of course, these are small numbers and the duration is also very small. So to summarize, to minimize the inhibitor risk, if feasible, start primary prophylaxis, especially in severe cases. Whenever available, use plasma-derived factor VIII clotting factor concentrate. Careful observation for inhibitor is very important, at least up to 50 exposures. Keep patient on the same product. Don't switch the product up to 50 exposure days. Avoid intensive therapy during early exposure days. Avoid switching products when the patient has intensive treatment, surgery, simultaneous infection or inflammation process, already has a family history, previous history of inhibitors. Thank you.
Thank you, ma'am, for this very informative but lucidly placed talk. Um, so we move now to the third part of this talk. As we understand that inhibitors in hemophiliacs can really be a matter of significant financial and debt to them, and it can be really nightmare both for the physician as well as for the patient. Now, with the increasing availability of bypassing agents and other different non-factor agents, armamentarium is getting more widened. But unfortunately, even then, a substantial proportion of patients in the LMICs still get deprived of all these products. To learn more on this advancing armamentarium to manage hemophiliacs with inhibitor, we have Dr. Tulika Seth, ma'am. I had a great opportunity to listen to her on this talk recently in Hematothon, but whoever has missed, this opportunity to listen and learn from her excellent talk on this topic. Over to you, ma'am.
Thank you so much. I hope you can see my slides.
Yes, ma'am, and you are clearly audible as well.
Thank you so much. So, thank you for the two very excellent talks. Dr. Archana's talk was extremely comprehensive, and the case that was presented was also very interesting. So, everybody here knows about hemophilia, and they know that these patients can have spontaneous, serious, life-threatening bleeding. And the inhibitors are a very serious complication because after an inhibitor develops, then the prophylaxis or the on demand therapy with the factor replacement, either factor VIII or factor IX, now fails. So, what happens now is that the patient becomes resistant and will continue to have bleeding and will have severe morbidity and mortality. And even though the clotting factors are very expensive, the cost of the bypassing agents and other therapies are even more expensive. So we end up with all the efforts that have been done tend to fail. So you've already gone over the exposures about when to test and how to test, so I won't go into that. But just to re-emphasize that we have low titer inhibitors and high titer inhibitors. Low titer is anything less than 5 Bethesda unit and high titer is more more than 5 Bethesda units. And a low responder is a low titer inhibitor who, even after repeated exposures to factor, remains a low titer inhibitor. And sometimes you can have a low titer inhibitor when you give an exposure to clotting factor, they become high titer, and these are called the responders. So, this is very important to remember because sometimes when an inhibitor occurs, we stop giving clotting factor, and over time, the inhibitor may disappear, and we think, oh, wow, fantastic, everything has now resolved. And when you challenge the patient with even a single dose of factor, suddenly from this very low undetectable inhibitor, you get a very high rebound, and that is called the anamnestic reaction. So, the main problem with inhibitors is, as I said, you end up with so many complications. And this is actually the worst thing that can happen to a hemophilia patient. And it's been beautifully described by Dr. Archana, all the things that you can do to try to prevent. But obviously, once this has happened, you can't do prevention. You now have to manage the patient. So we can't use clotting factors. We also cannot use FFP or cryoprecipitate. In the presentation, once you had identified an inhibitor, I think there was some issues with bypassing agent and recombinant factor 7 was used, but also there was some FFP that was given. So both FFP and cryoprecipitate work because they contain clotting factor 8 and clotting factor 9. And once you have an inhibitor, FFP and cryo should also not be given. So we use bypassing agents. So what are the available bypassing agents that we have? We have FIBA, and we have recombinant factor 7A. And we also now have emicizumab, which is technically not a bypassing agent, but we'll talk about that in detail. So once we have a patient who has inhibitors, we have to check if it's a very low titer inhibitor. You can get away with just using increased factor 8. But if you have a high titer inhibitor, or if you have a patient with inhibitor who needs to go for surgery, you should use bypassing agents. And as I said, we have FIBA, which the full form is factor 8 inhibitor bypassing agent. And we have Novo 7, and we also now have some indigenous brands of these. So in case you don't have bypassing agents and you have a very low titer inhibitor, maybe 2 Bethesda unit, 3 Bethesda unit, by using this formula, you can calculate how much clotting factor that you need for controlling a bleeding. And this comes to roughly about 3 times the usual dose that we give to a patient without inhibitors. The conventional bypassing agents, as I said, are APCC and recombinant factor 7A. Now, APCC contains many clotting factors. It's a plasma-derived product. It primarily contains activated factor 2, 7, 9, 10, and some small amounts of factor 3. So it's important to know that this does contain factor 9. So in case we have a hemophilia B with inhibitors, you need to be very careful. And usually in hemophilia B patients with inhibitors, we avoid APCC because it does contain factor 9, and they may develop anaphylactic reaction to the APCC as well. There is also a factor 10, which interacts with the platelets and promotes thrombin production. And the thrombin then promotes the conversion of fibrinogen to fibrin, and the clot formation occurs. APCC can also be used in other deficiencies like factor 10 and other rare deficiencies. Recombinant factor 7A is a recombinant product, and this activates the factor 9 and 10, and it leads to an initial and it leads to the thrombin burst. So these are two ways in which we can use these products. They both have advantages and disadvantages. The dose of FIBA that we can use is 75 to 100 units per kg. It can often be given once a day as 85 units per kg. The maximum dose should not exceed 200 units per kg. That would be 100 units per kg twice a day. So that's the maximum dose you should use. You must remember that these are very strong products and they can lead to thrombosis. And even though we are worried about bleeding, but thrombosis can also be life-threatening. FIBA has multiple uses. In patients who have an intracranial bleed, we want to have a sustained control and prevent rebleed. In surgery patients, we also want prolonged control. And so FIBA is usually the preferred bypassing agent for surgeries and for patients who have intracranial or other serious bleeds like an iliopsoas bleed. Recombinant factor 7A is also a very important bypassing agent, and this works very rapidly. And we usually give about 100 micrograms per kg. The problem with this is it has a very short half-life, and so every 2 to 3 hours you will repeat it. In case you have a patient who continues to bleed, you should again repeat the dose, because sometimes the second or dose may control the bleeding. And in a major study, they actually found that 2 doses of recombinant factor 7A were equivalent to 1 dose of FIBA in the bleeding control. FIBA can also be given as a larger dose of 270 micrograms per kg as a single dose, in case you don't want to keep repeating the dose every 2 to 3 hours. Now, we talked about prophylaxis with factor 8 for hemophilia patients without inhibitors, and patients who have inhibitors sometimes can have a very high ABR, that's the annual bleeding rate, and if they have a target joint, they may continue to bleed and may come to you every day requiring bypassing agents. And so such patients were put on a bypassing agent prophylaxis. And because the bypassing agent was given on alternate days, usually FIBA is recommended because it has a longer half-life. And they found that patients who were on FIBA at the dose of 85, approximately rounded off units per kg every other day, had much better joint outcomes and less bleeding than patients who were not receiving this. So it's important to remember the dose is very important. So often, as I said, when I see patients who are using doctors who are using recombinant factor 7A, they give 1 dose and then they sit down. So it's important to know that you have to keep repeating the dose every 2 hours until hemostasis is achieved. Once you've achieved hemostasis, also you have to continue to give recombinant factor 7A, and you can stop anytime. So this is what you would use for a intracranial bleed or a serious bleed or a surgery patient. For minor bleeds, sometimes 1 dose is sufficient. And these are the UK HCDO recommendations. And again, they basically follow the same. And it's important again to remember not to exceed the dose of APCC beyond 200 IU per day. You may consider tranexamic acid as an adjunct, but you need to remember, if you are doing more than 2 things, you need to be very, very careful, and you need to monitor patients. If you're using tranexamic acid, which we have very easily available to us, never use a large dose of FIBA. In fact, I would recommend that if you're using tranexamic acid, then your total dose of FIBA or APCC should not exceed 100 IU per day. In the WFH guidelines, they also have a regimen of alternating APCC and FIBA for life-threatening bleeds. But again, remember, if you're using a combination of anything, tranexamic acid, APCC, or FIBA, you need to be very careful and monitor these patients either with a TEG or any other kind of an assay, because you may end up with thrombosis. Unfortunately, in spite of these very good agents, we often find that patients have a poor control of bleeding, and they may have recurrent episodes of bleeding. They also may end up with thrombosis if we're using these agents too enthusiastically. So there was really a need for better things. And so there are many unmet needs. Novo 7, which is the recombinant factor 7 we use, has a short half-life, and the prophylaxis with most of both of these agents, the bleeding control is not as good as we would like. So patients continue to bleed with this. So what does WFH say? So WFH says that yes, you can use these products, but it also mentions another agent, and it says that patients can also receive emicizumab. So patients who have who have inhibitors and continue to have bleeding can use this. So what exactly is what exactly is emicizumab? So emicizumab is a bispecific monoclonal antibody, and this replaces the action of the activated factor 8A, and the emicizumab directly binds factor 9A to factor 10 and allows the activation of factor 10. So there have been many studies, starting out with the Haven 1 study, where they found that patients with inhibitors had a significantly reduced annual bleed rate in their joint, spontaneous joint bleeds, and even in the target joints, there was a marked reduction. So there was a good improvement in both the target joints as well as in fact, there was a 95% reduction in the bleed that occur in a target joint. And a target joint is, as you know, a joint that has been damaged and has more than 3 bleeds in the same joint in 6 months. And in fact, a large number of patients actually had 0 bleeds in a target joint. And just to let you know that even with prophylaxis, high dose prophylaxis, we are usually not able to achieve 0 bleeds. So this was really good. And there were a large number of patients who actually had completely recovery in their target joints and complete 0 bleeds. And there was not too much variability. So even adults and other patients who had been on prophylaxis, there was an improvement. So patients who had been on bypassing agents, once they were put on emicizumab, again, there was a dramatic improvement in these patients as well. So the conclusion showed that patients, pediatric and adult patients who were on the emicizumab had a very good and it was very safe, and the amount of bleeds was substantially reduced. Now, when we're using this monoclonal antibody, we must remember that there is an initial 4-week loading dose so that we can get to a standard level. And the loading dose is 3 milligrams per kg weekly for 4 weeks. After that, you can either dose it at a lower dose of 1.5 milligrams per week if you've reached your plateau, or you can do 3 milligrams per kg every 2 weeks, or you can even go to 6 milligram per kg every 4 weeks. So it can be given monthly. This is a subcutaneous product, and it has a very long half-life, and it can be used in patients with inhibitors and without inhibitors. So WFH also says that this is really, really important, and you can use this, and it can be used in patients who have high responding factor VIII inhibitors. And the only thing is that this is used as prophylaxis. So you will give it initially the 4 weeks, the loading dose, and then you'll give it either once a week or every 2 weeks or every month to prevent bleeding. But if you have bleeding on emicizumab, then you must remember that, again, what I talked about combination. So now you'll be adding something else to these inhibitor patients if they have a bleed on emicizumab. And the recommendations are that you give them a dose of recombinant factor 7A for any breakthrough bleed. This could be a spontaneous bleed or it could be a traumatic bleed. It's important to remember to avoid APCC or fever with emicizumab, because when they did the study, they actually found that a few patients had developed angiopathy, thrombotic microangiopathy, and that was due to this combination of APCC along with the emicizumab. So whenever you're adding two agents, you need to be really, really careful. So in the Haven 4 study, they looked at patients on the 4-weekly regimen. So these were older patients, and they found that this was also very effective. And this is a regimen that can be used for patients who live far away. And these patients also had 0 bleeds, and once it was understood to avoid APCC, the safety was found, and there weren't any problems with this agent. And this has now been expanded for even a longer period of time. And again, no further thrombotic episodes were found in these patients. And this is what it looks like when you're giving the dose either weekly or every 2 weeks or every 4 weeks. But it's important to remember that you must give 4 weekly doses in order for the patient to get to this plateau level. Sometimes people just give one single shot That's not really the way it should be used, and you will not get the full benefit of the product. Once you get to the plateau after the 4 weekly doses, you can, because the cost is there, you can then use lower doses or less frequent doses, but do follow the weekly regimen at the beginning. So emicizumab is a new agent that we have, and just to summarize, I'll just present one short case. And this is a patient that we had who presented with a very high titer inhibitor of 512, and he had obviously not been able to get prophylaxis with bypassing agents, but was just getting episodic bypassing agents. But even with that, was having a very high bleed rate of 6, and he had a target joint, he had his exams that were coming, and it was really a big difficult situation. And so this patient was started on emicizumab. The other thing to remember is, before you start emicizumab, if you have been using FIBA, then you should have a washout period of at least 24 hours before you start the emicizumab, and this is recommended by several organizations. So it's a simple thing to do. It just takes 24 hours, and then you can start. And the vial strengths are several. And as I said, you must do the weekly loading dose before you do the maintenance dose. And there are now several groups, including Dr. Neeta Radhakrishnan, who are giving lower doses over time. But as I said, please do the proper loading dose for the initial 4 weeks, and then you may stretch out the time in case you have a cost thing. The only problem with the emicizumab is some of our usual Bethesda assays and other tests that we do are inhibited. And so if you want to know what is happening to the inhibitor, you will then have to do the bovine chromogenic assays to monitor these patients. So as I said, if you have a bleed, you need to treat the bleed, and that bleed should be treated with recombinant factor 7. And even a 50% dose of the recombinant factor 7 is often effective enough to treat a bleed in these patients. So the lowest dose of recombinant factor 7 can be used. And remember, we had said that you should give at least 100 micrograms per kg. If the patient is on emicizumab, you can actually control many bleeds with only a 45 microgram per kg dose. So that is, again, very useful, because all of us have a shortage of bypassing agents. In case this fails, then you should go to the full 90 microgram per kg dose. And APCC should be avoided, but in case you're in a life-threatening situation and you have nothing available, in that situation only should APCC be used. And if you're using APCC along with emicizumab, be very, very careful and do not exceed the dose of APCC beyond 50 units per kg per day. So normally we can go all the way up to 200 units per kg per day when we're using it alone, but in this situation, not more than 50 units per kg per day. So emicizumab is a non-factor product which has a long half-life. It's a subcutaneous use, and no monitoring is needed. So this is definitely added to the armamentarium of the 2 standard bypassing agents that we already had. But as I said, the care of inhibitor patients requires a lot of planning. It requires a lot of medication. So your hospital and stores needs to help you. The government is helping in many of the states, and we need to be able to talk to our laboratory people for good monitoring. Thank you.
Thank you so much, ma'am, for this elaborate lecture on this topic. In the chat box, I don't really see any question as of now. I have a question, ma'am. We understand that when we are using these bypassing agents, the conventional coagulation parameters like PET becomes unreliable, and one has to do more complex kind of studies of coagulation by using either thumb elastography or rotem, etc., which are often not available at the care. What do you suggest in such situation? Apart from clinical monitoring, is there any other way of looking into, are we giving the bypassing agent at optimal doses? How can we really monitor?
So that's a really good question, and the short answer is we don't have anything unless you're doing a good TEG, ROTEM, or a thrombin generation study. And all three of those, as you rightly said, are not always available to us. But many ICUs and many trauma units are using TEG. And I think that it is important for us to also use it because it is a very good point of care assay. It doesn't tell you exactly what's happening. It won't give you like a APTT value, but it'll just tell you if you're going towards thrombosis or if you're more towards bleeding, and you can balance things out.
Right, ma'am. So another question again to you. So I know it is not the platform to discuss on ITI in detail, but ma'am, can you please briefly can you share your experience of ITI at your center?
Okay, so thank you. We were very fortunate to be part of the SIPIT study, and after that, we actually had one patient who had a permanent inhibitor, and so we talked to Dr. Manucci, and we got a immune tolerance induction study with Dr. Manucci, which was really nice because it gave us some experience, and then after that, we did more um, immune tolerance induction. So, immune tolerance induction, if you use the low dose, is actually very similar to doing prophylaxis. The only thing is you need to make sure you have enough product. You need to make sure you're able to monitor the patient and you have some bypassing agents to treat a bleed. You also need the family to be very compliant because interruption of ITI will lead to failure. And if you select the right patient, so what we did was we took children who were less than 10 years old. We took children who had low titer inhibitors, so they had never had like 100 Bethesda unit or anything like that. And we selected them within a year of developing the inhibitor, so they had not had inhibitors for a very long period of time. And in all of our patients, we took 5 patients and we were able to get 100% of them inhibitor free. And in fact, just recently, the first patient that we had done, the one who had actually been on the SIPIT study, came back to us and he's now 7 years inhibitor free. The other thing you must remember is once you do the ITI, you need to put them on some kind of prophylaxis, even if it is a low dose prophylaxis, because otherwise they may relapse. So ITI is something to do. I would recommend in India because of cost problems, choose and select the right candidate so that you can be successful. Patients with high titer inhibitors do better if you use the high dose ITI because they'll have less bleeding and they have better chance of inhibitor eradication, but that is too expensive for us.
Thank you, ma'am, for sharing your experience. In the chat box, there is one question written Naveen who is asking about a new agent, fitusiran. Is it a bypassing agent, and what is the current situation of that drug in this?
Okay, so emicizumab is a non-factor agent. We talked about that. That's a monoclonal antibody, and we have fitusiran, which is a RNAi agent. And basically, so there are new products that are coming which are rebalancing. So we have concizumab, we have fitusiran, we have marstacimab. So there's several new products that are coming. These are all under trial. They're not approved in any country as yet. We are doing a concizumab trial. There are many of my colleagues who are doing fitusiran and marstacimab trials. These, as I said, are rebalancing agents, and they basically increase the thrombosis. Fitusiran is once a month subcutaneous. Concizumab is a daily subcutaneous injection given by a pen injector. So these are all very exciting things that are coming. The nice thing about concizumab and fitusiran is they can be used in both hemophilia A and hemophilia B with inhibitors or without. So emicizumab, unfortunately, we can only use in hemophilia A with or without inhibitors.
Another question, by Dr. Sanjeev, that whether switching clotting factor concentrate brand is a risk factor for development of inhibitor.
So that's actually a really good question. I found one study, it was from Scotland, and they had done a meta analysis and they had looked at that. And what they found was really interesting. They found that there was an increase in inhibitors when patients were switched from one brand to another. And that was particularly more so if patients were on and this was more so for the plasma derived brands. Now, this was a very old article, Subsequently, there has not been any real study on this. The only other study that came out was from Canada when they switched from plasma derived to recombinant. They did not find that. As the previous speaker had highlighted, there was a problem with the second generation full length recombinant factor 8. Now we mostly use the third generation factor, and most of the time it is B domain deleted. There seems to not be so much difference. Another comment I just wanted to make about the SIPIT study was that even though they did find that there was slightly more inhibitors with the recombinant, when they went back and they looked at the mutations, what they found was in patients who had low risk mutation, the benefit of plasma derived factor was in those patients. So if those patients were given plasma derived and they had a low risk mutation, then they might get less inhibitors. But if somebody had a high risk mutation, whether they were given recombinant or whether they were given plasma derived, it didn't make a difference. They were going to develop inhibitors and they got the inhibitors irrespective of the factor. So the mutations are really important. Family history is really important. The product may or may not have too much of a role. So that question still is not completely answered, and I think it's difficult to prevent. Also, in the SIPIT study, we had out of our patients who were on the SIPIT study, 4 developed transient inhibitors, and only one of those 4 had a permanent inhibitor that required an ITI. So just because you find an inhibitor doesn't mean you are now stuck with it for life.
Thank you, ma'am. I would request Nita, the administration ma'am, to share a brief note on your study on low dose emicizumab prophylaxis. It is really pertinent in the context of LMICs. Hello, ma'am. Are you there? Okay, anyway, so I think there is some problem. Another question, ma'am, with the there is new advent of this extended half-life products. So do you think there is any data that giving prophylaxis with this EHL product, is it protective from development of inhibitor as compared to conventional product prophylaxis?
The current data that we have does not suggest that. They both have, especially in the PUPs, that's the previously unexposed patients, those are the patients we have to be really careful about. So there's no benefit to using extended half-life in that. But at the same time, if you're using it in previously exposed patients, there is no increased risk of inhibitors. So these are safe products. The only advantage is they have a longer half-life. But there is actually a very interesting thing since you mentioned. For when we talk about ITI, there has been one study where they did ITI, immune tolerance induction, using the extended half-life products, and they found that the time to achieve inhibitor eradication was shorter if you used an extended half-life product, probably because there's a longer exposure and you're able to eradicate the antibody faster. So there are several studies that have now come out, even though they're small studies. So this may be for people who are planning to do ITI, this may be one strategy to use.
For clarifying. Now, the session is open for comment by other wise people in the group. Ma'am, you can see Dr. Manas Kalra sir, Lenny Matthews ma'am, anyone can kindly unmute yourself and share your experience or any comment in this context.
So hello everyone. We have recently started using emicizumab, and the problem is that sometimes the supply is not very consistent. I mean, they may give us a product which has a very short half-life, and if we put too many patients on the emicizumab, then we are sort of constrained that what if the product is not available in the next month. So that is what, otherwise the NHM is giving a lot of concentrates and the bypassing agents and emicizumab also. So that is what we have faced in the last 2-3 months. And we have about 5 patients on emicizumab right now. So we don't have a very large experience, but maybe in the next 6 months, we may be wiser. with the use of emicizumab.
So first of all, congratulations. I think that's lovely that you have emicizumab. And just to let you know that during the COVID time, we also had a problem with supply. But if you can do the loading dose, the 4 doses, we then actually had some patients who were on 1 dose every 6 to 8 weeks even, and none of these patients bled. And I think Neeta had some technical issues, but she will also tell you that they are using a much lower dose for the maintenance phase of emicizumab, and they are doing really well. So this is a product that I think, if you've done the loading dose, you may be able to then use it in different ways later. And I saw that there's a question by Dr. Manas. I think my time's running out, so I'll just quickly answer Dr. Manas Kalra's question. So the WFH says the first ITI should be done only with the clotting factor concentrate with which the patient developed the inhibitor. So that is the World Federation of Hemophilia recommendation for the first immune tolerance induction. In case a patient fails, then they say to go with rituximab or immune suppression. You have to be very careful with the immune suppression because that may increase risk of infections, and also the rituximab often may eradicate the inhibitor for a short term, but it may not necessarily be efficacious over the long term. So we're, as I told you, we're looking at 7 years, 8 years, 10 years down the line. So that is the only thing to remember for that.
Right. So here I think we have reached near the terminal part of the session. Again, I express my heartfelt gratitude to all the 3 speakers, Dr. Chandana, Dr. Archana, ma'am, and Dr. Tulika Seth, ma'am. I don't think we would have been able to arrange any more better session on hemophilia with inhibitor than what we had. Excellent discussion it was. Thank you to all the speakers again. And I will just beg 2 more minutes to bear with me to another next session. Our next session will be on 8th of December. Again, we are discussing on a very interesting topic on a malignancy, which we all pediatric oncologists are very happy to treat simply because the malignancy has an excellent outcome. It's malignant germ cell tumor. So the primary center to participate to discuss is Rajiv Gandhi Cancer Institute and Research Center from New Delhi. And to have expert presentation on the management aspects, we'll be having Dr. Raghu K. Sukumar, who is the senior consultant at Tata Medical Center, Kolkata. Thank you all for your participation and the interaction. Thank you.
Thank you.
Conclude for.
I request everyone to kindly log into your iEcho account and then fill the feedback form.
Oh, yes. Thank you so much, Eco team. So kindly give all the audiences a request to give their feedbacks. Thank you so much.
Thank you, everyone.